Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Welcome to special conference coverage from the 2026 Elevate-Derm RAPIDS Conference. I'm Victoria Garcia Albea. I'm a nurse practitioner practicing in dermatology outside of Boston at a hospital called Leahy Clinic. And I am joined here by Dr. Gupta, who is an allergist. And she has given us some excellent talks today about the interplay of dermatology and allergy. And so are there some key takeaways from your lecture on hives that you'd like to emphasize for our listeners?
Yeah, so I gave a lecture on chronic spontaneous urticaria, and I think some of the key takeaways is that mast cells are the major drivers of CSU pathophysiology, and there's multiple areas with mast cells and processes that result in their degranulation that we need to think about. So there's the high affinity Fc epsilon R1 receptor on mast cells, and the cross-linking of that receptor definitely causes mast cell degranulation, but that cross-linking can happen in different ways. In our CSU patients, we know that there is autoimmunity and autoallergen components, so type 1 and type 2b endotypes that are playing a role. And in our non-CSU patients, we know that there's other external factors that can result in that cross-linking. And so that's something that we need to think about. Also, BTK phosphorylation internal into the mast cell and how that propagates the degranulation and mast cell activation is also really important to think about. And then, of course, IL-4, IL-13, and how blocking that mechanism can also affect mast cells and the effects that are downstream from degranulation and how that affects our CSU patients in as far as the pathophysiology. And then also, as I mentioned, that in CSU we found that there's two endotypes. There's type 1 autoallergic endotype and there's type 2b autoimmune endotype for CSU patients. These are the two that we know about. They can coexist in the same patient. And then also some patients may not have either endotype. And that's also important to remember as we're treating our patients and as we're looking at future therapies. And the therapeutic landscape is actually changing in CSU, which I love because as you continue in medical education, you realize that every day is a new day, right? And so you blink and there's changes in what we find in the therapeutic options that are available. And I love that for our patients because every human body is different and what might work for one person doesn't work for the other. And our goal is really to help our patients. And without these therapeutic options and lots of therapeutic options, we may not be able to help every single patient. So I really appreciate that there's so much research being done in CSU and that we're having more and more options available for our patients to try if one doesn't work for them. And then the last thing that I want to touch on from that lecture is just to remember that we're ensuring that patients are given all of their options. It's really, really important. And I would say that even at the first visit, we talk about all of the advances that have been made for our patients with CSU so that they're leaving the office visit hopeful, right? Because our patients have usually been on a journey, right? They've been to multiple subspecialists. They've been in this cycle of not feeling good for a while. And we want to make sure that they understand that we know that they've been to multiple providers and that they might have tried multiple therapeutic options, but that we're going to help them find what fits best for them and that there are so many options available.
I love that you empower your patients, and it sounds like you employ a lot of shared decision making, going through the whole gambit of different options depending on what the patient might be ready for or might be nervous about starting. But you give them, I try to do this too. If this doesn't work, I have other things. These are the other options. We may not need it now, but perhaps if this, isn't working for you or you're getting side effects or whatever, we have other options. Come back. Let me know if it's not working.
And I think that's the difference between, I don't want to say good provider and bad provider, but that I think that we really need to be doing that. And I know that our visit times are limited. And sometimes when we get that patient that for example, is only on once a day second generation antihistamine, and we're like, oh, they're probably going to respond to, increasing them to 4 times. I'm not going to go into the whole spiel about all the other therapeutic options that are available. We're not saying that you need to go into the whole spiel. We're just saying that you want to make sure that you mention it, right? You don't need to tell them about all the side effects. You don't need to tell them about omalizumab, dupilumab, remibrutinib. You don't need to go into every single medication, but you just want to highlight that we do have more advanced therapy options if the second generation antihistamine option fails.
Do you have a handout that you give patients that breaks down the different classes of medications, or do you direct them to, a foundation or a website, something like that?
Yeah, there's definitely so many resources out there. I'm not a paper girl. I really like my clinic to be low resource, I guess, low paper resource setting. But yes, I actually refer them to my podcast. So I
Nice.
do have a
Wait,
podcast.
shout your
Yeah.
podcast out.
Yeah, so it's called The Itch, and it's primarily technically meant for patients, caregivers, but we do have a lot of providers listening to the podcast because I think it's nice to get a different perspective on how to talk to your patients about their conditions. I think oftentimes in medical education, we learn a totally different language that we're just getting used to learning, and then we lose sight of what we were like before we knew that new language, right? And so we forget that we now understand what different words mean that like prognosis and diagnosis and et cetera, that our patients might not really understand, right? And they might feel really confused when they're leaving their visit because we're speaking in a different language. And so I think that we try in our podcast to keep the language at a patient centric level. But again, oftentimes it's helpful for even practitioners to listen to
Absolutely.
and understand. But yeah, it's a good resource for patients and providers, hopefully.
That's excellent. I'm going to have to subscribe. So, moving to one of your other topics from this weekend, you were talking about allergy testing. And so, talk to me about the hidden risk of food avoidance.
So, this is a big one, right? And this happens in so many conditions that dermatologists see, from CSU, chronic spontaneous urticaria, to atopic dermatitis. People want to figure out what may be making their condition worse, right? And that can be children and it can be adults. And so when patients start restricting their diet, avoiding foods that they think might be causing their symptoms, that is a huge problem. It can result in a lot of anxiety for patients around mealtime, right? And we're supposed to eat, right? Eating is a part of our sustenance. We need to eat in order to live. So, creating anxiety around something that we have to do really leads to a lot of discomfort for patients. And then secondly, when patients are avoiding foods, we also see nutritional deficiencies depending on how many foods they're avoiding. I've had patients come in with 10 to 20-pound weight loss. I've had patients that are just really eating 1 to 2 foods only because every single thing seems to potentially be a trigger because it's actually an internal pathway that's causing their hives, especially in CSU. And so it's not external factors like food. And so this is really where we need to be helpful to our patients. We need to help them understand what the actual pathophysiology is of these conditions, what's actually happening in the body to cause these conditions, and make sure that they understand that we need to undo some of that restrictive food practices and that we can help them do that. And I think that that is best done with coordination with an allergist because we're so used to doing that. We see that with patients who have food allergies, atopic dermatitis, CSU. We see that in so many conditions that we know how to undo those things. We know how to interpret testing. We know how to do appropriate testing in order to help patients feel confident and comfortable. And we also do oral food challenges in order to help our patients feel confident that it isn't this food or that food that's causing their symptoms.
And I feel like that could lead perhaps someone like myself down a rabbit hole where I'm interviewing them and they have hives and then they tell me they've lost all this weight. And I'm like, oh my gosh, that seems very severe. If I don't ask about the food history, which I may not, then I'm going to be more concerned about some kind of systemic issue, like lymphoma or whatever.
Absolutely. So weight loss is always scary as a practitioner. When
Yeah.
you hear weight loss, you
You perk up.
automatically get triggered and,
Yes.
we want to make sure that we're not missing something. And so, yeah, food restriction and being, like again, a 1 or 2 food diet is
Mhm.
common in our patients that we share. And so talking about that and understanding what patients are doing is really important, especially when you hear that history of weight loss.
Do you have a magic one-liner that cures patients of trying to restrict their food because they are thinking it's gonna cure their hives, or not really?
I would say that, yes, I kind of do. So I talk about how important food is. Number one, I talk to them about how important it is and how restricting the diet can cause all of these problems. But then I also talk about how we understand chronic spontaneous urticaria and we understand that it is an intrinsic process, that it's something that's happening inside of your body and it's not the external environment that's causing this condition. So we talk about how it's a chronic condition. We talk about the pathophysiology, to be honest, about what's happening inside of the body to cause the condition and making sure that the patient understands that.
I'm gonna tune into your podcast because I'm sure you go over that in patient-friendly language.
Yes.
Excellent. I'm going to switch gears a little bit. So, if patients have a known food allergy, how come sometimes they can tolerate a baked allergen?
Yes. So that's a really good question. So we see that in milk and egg in particular. And so what happens when you heat a food up at high temperatures is that the food protein actually changes. Okay. So the way that the body sees that food protein changes, and it's not the same as it was before it was baked. And so we have tests that we can do for egg, for example. We have this component testing that looks at the different proteins, the egg that you can be allergic to. And there's something called ovoalbumin and ovomucoid. If you're ovomucoid positive, that means you're likely not going to tolerate baked egg. If you're negative, then there is a possibility that you can tolerate baked egg. And we would do a baked egg challenge in those kiddos to see if then they're progressing out of their food allergy. And so that is one of those ones that we definitely look at that because tolerating a baked version of something that they are initially allergic to can help them progress into growing out of their food allergy, specifically for milk and egg.
Is that a blood test?
It is a blood
It's a
test.
blood
Yes,
test, so it's
it's a
pretty
blood
simple.
test. Yep.
Okay, what are the benefits of aeroallergen testing?
So, aero allergen testing, so that means testing for allergens like dust mite, trees, grasses, weeds, pets, those kind of things. That is what we call aero allergens. So, things that are in the environment that are environmental, right? And so, that kind of testing we reserve for patients that clinically are telling us that they have signs of allergy, right, to a specific thing. So, every time I'm in a room with a cat, I have XYZ symptoms.
Mhm.
So, and these patients may say, when I touch a cat, I get hives, right? Or when I've been in a home with cats, the next day my eczema is definitely worse, right? And so when there's a 1-to-1 correlation with that allergen, we really then can look into aeroallergen
Mhm.
testing specifically for things like urticaria, not CSU, right? But urticaria, if a patient's having urticaria in those settings, or for a patient that's having exacerbation of their atopic dermatitis, right? And so for aeroallergen testing, I'm not as worried about doing a panel test for aeroallergens, right? Because it's technically not as kind of dangerous as doing a panel test for food, for example. So with panel testing for food, so if you test any of us, if you test 10 individuals for like 20 different foods, those 10 individuals may have a positive randomly pop up, right? A false positive test. But when you get that false positive, then what do you do with it, right? The person's like, well, I eat onions every day. Well, I have hives every day. So now what, am I allergic? No, you're likely not allergic, right? And so that's when that food restrictive diet comes into play is some of these patients get these tests on their own at like a Quest or a LabCorp because you can now, and then they don't know how to interpret the testing, right? That the clinical history has to match the testing history. So that's really important. But for aero allergens, I'm not as worried. If you find out that you're allergic to trees and grasses and maybe it was a false positive, you're not going to do anything, right? You're not going to all of a sudden cut all the grass all over the world, right? To try to get away from grass or all the trees. You can't do that. So I'm not as worried. I mean, however, it could make somebody stay indoors more, or it could lead to other issues. But again, we try to rely on history and then test the individual as much as possible.
So fascinating. I love hearing from people who work outside of dermatology. It really opens up our perspective. Give us some key takeaways from your case discussions on atopic patients.
Yeah. So I think that there's certain things that we really need to remember. Number one is that atopic multimorbidity, which means that having more than one atopic condition is very common. So atopic dermatitis and asthma frequently coexist. And that's because of the shared type 2 inflammatory pathways that exist in these conditions. And also that there's something called the atopic march, right? And so if we have a little baby that has atopic dermatitis early on, and they are starting to get sensitized to their environment through their skin barrier that is not fully there, right? So, meaning their compromised skin barrier, and that can then predispose them to having asthma and allergic rhinitis down the line. So, the atopic march usually starts with atopic dermatitis, then goes into asthma, and then goes into allergic rhinitis. And actually, I personally fit that to a T. I had atopic dermatitis, then I got asthma, then I got allergic rhinitis. So that is why I'm an allergist.
Do you ever see it the opposite way or mixed, where someone might have seasonal allergies first and then they go on to asthma or maybe just not very often?
No, no, absolutely. So, it isn't always in that order. However, we tend to in infants, if we're talking about the atopic march starting in infancy, for infants, we tend to see potentially asthma early on or atopic dermatitis early on. As far as allergic rhinitis, that usually presents more after two. So you really have to be sensitized or exposed, I should say, to your environment for at least 2 years before we start seeing allergic disease related to the external environment. And then number two, type 2 biomarkers can guide treatment, right? And so elevated IgE levels, eosinophil levels, something called a FeNO, which is the fractional exhaled nitric oxide, which is a breathing test, can predict response to biologics in our patients. So, and this is essential for phenotyping and treatment selection. So, really relying on some of these measures that we have in helping our patients decide what treatment may be best. And that goes into number three, which is personalized medicine is the approach that we're kind of going towards.
And I think
And
everybody loves that.
yeah, I think everybody loves that because we love to be able to have guidance on what we want to tell our patients to do next, right?
And know that
When
it is more likely to work.
Right. And know that it's more likely to work so that we have a happier patient, right? And then we have a patient that's not cycling treatments and not feeling better and getting discouraged because we know that's not good for their mental health and it's not good for the medical system in general, right? And so matching the treatment to the patient specific phenotype and comorbidities and addressing that shared pathophysiology can help also improve compliance because they're going to get better. And then also having one drug as opposed to two drugs that are helping with their conditions, with their shared conditions, is also going to improve compliance. And then, lastly, comprehensive assessment is critical. So, evaluate all atopic comorbidities, consider the impact on their quality of life. Do not undermine allergic disease because ultimately, yes, it may not lead to mortality. Ultimately, these conditions may not lead to mortality. However, I would mention that asthma still has a death rate of 11 patients a day in this country. And so they aren't benign conditions. Asthma can be very severe. And so we want to make sure that we understand that and that also atopic dermatitis, CS, all of these conditions can cause so much distress to our patients and impact on their quality of lives and further impact the underlying anxiety and depression that many of our patients already face.
That is shocking. I want to refer all my patients to allergy now, but I know that's not practical. Just like a couple of quick key pearls. When should we collaborate with allergy? I'm lucky I work in a hospital. I can message my allergy team through Epic. Not everybody has that luxury. So, should we all make friends with our local allergy team? When should we really refer to an allergist? What are some of the maybe red flags that you would think of?
I think in that atopic individual where you do have multiple comorbidities, if the patient isn't already being managed by an allergist, like if they have asthma, if they have environmental allergies, in that patient, if you feel like they're not effectively being managed in those other conditions, managing those conditions can then help with the treatment of whatever you're treating, right? And so I think as allergists, we are kind of considered the primary care kind of doctor of these atopic individuals. And so we can really help define environmental measures that may help, undo some of this like food restriction, especially in our patients. And then if you're not comfortable using some of the biologic medications, like I know some of my dermatology colleagues never really got comfortable with omalizumab, for example, because of that risk of anaphylaxis, then I think that's another reason to work with your allergy person so that you can help your patient get all of their therapeutic options.
Excellent. So we really covered it all: collaboration, personalized medicine, listening to the patient, shared decision making. Thank you so much. Any last words of advice or?
No, I think I just love this crosstalk that we have going on. I'm really happy to be able to talk to my dermatology colleagues and then for, just to be able to think about these patients together as opposed to in our own little silos.
Absolutely. This has been special conference coverage from Rapids 2026. Thank you so much for joining us.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.